In the meantime, we are finding other profiles, patients who obviously not just have high titers to both, who have chronic fatigue syndrome. We have patients with very high titers to HHV-6. Dr. Chia mentioned something that we have also noticed in our patients, the trip to Mexico, the trip to India, to Africa, and when they return with the stomach flu-like onset, and then they come with, there is one patient, for example, we had the luxury of having the HHV-6 titer low measure for another reason. The December is the onset for this patient, and the titers go 6-fold higher after the episode. To tell you the truth, these patients have been harder to respond to therapy. Only 1 out of 4 patients who have this profile have responded, and we want to obviously gather more numbers before we go public, truly public with this. There are patients who have very high EBV and very high HSV1 or EBV and HSV2, and it's classic, the patient who tells you that every time that they have a genital herpes outbreak, their CFS symptoms worsen significantly, or the patient who gets a new partner who gives them HSV2, and that's when they say that was my onset of the chronic fatigue syndrome. And those patients, we tend to intervene more with acyclovir-like drugs rather than ganciclovir. We have several patients, including the daughter of a professor at Stanford, with clear-cut brucella, and they have, again, responded to nice, very targeted intervention to brucella. Same for chlamydia, same for mycoplasma. We have not been, and that's what I asked Dr. Kerr earlier, we have not been lucky with our parvovirus B19 subsets. Ours had been DNA negative, though, GM positive, but when we intervene, we have similar, only 1 out of 4, but it's not that clear. The other 3, they have worsened, and they don't. So still we want to pursue that avenue, but we'd love to see other interventions or more data in that regard. So I think that we are past, for this group, we are past the issue, this is a real disease. This is no question, it is a real disease, but I just want you to be aware that 50% or greater of the medical community, even in mainstream settings, still think that it's not real. So anything that is done in that regard to change that perception, perhaps through carefully done systematic work, will be very important. And which disease is this, or which of the aspects, depends many times on which area we are looking at. Such a complex disease is systemic, it lasts for years, there are subsets most likely of patients, and then over time, there may be, if you look at patients who are ill for 5 years, that profile may be completely different of patients who have been ill for 15, 20 years. So when one looks at biomarker parameters, one perhaps have to correct for these issues of length of the disease, perhaps to have a more homogeneous approach in the way of the biomarker that you are looking at. Just similar to what happens with pneumonia, these are 6 common pathogens for, it's the same syndrome, community-acquired pneumonia, similar to what we can say chronic fatigue syndrome, but look at all the pathogens that can do, and then if you look at different epidemiological settings, the list is almost endless of different pathogens that can do the same syndrome. So the hypothesis that we're working at Stanford is chronic fatigue syndrome is the convergence, is the syndrome that comes from many points, from many etiologies, including the possibility that there may be some non-infectious etiologies in these patients. So we hope that one day many gaps can be can be found and met through the work that everyone is doing from different angles. Thank you.